Very good morning to all of you, and thanks to Dr. Vishali for letting me talk before her talk, and thanks to Dr. Suresh and Dr. Pavel for having us here on this PG teaching session. So it's not a very simple topic to talk on recurrent uveitis because you don't have a very standard protocol or a consensus to treat any kind of uveitis which is recurrent. So I'll show you some kind of examples and how the clinical situations we face and how you can manage these situations. So first of all, we need to know the definition of recurrence of uveitis, and as given by the Sun group of Sun classification, it is defined as repeated episodes of uveitis separated by periods of inactivity or quiescence without treatment, and that means you should have an inactivity of at least 3 months in duration. But practically, we don't face this situation in our clinical practice. So what we face is the next situation, which is a chronic uveitis. We have these patients coming with on and off episodes of uveitis, and you really don't know whether to place them in a recurrent category or a chronic, because by the time you place them in a recurrent, they're already in chronic phase and a lot of damage is done. So the recurrent uveitis, the problems with it is that it can negatively impact vision. It causes extensive collateral structural damage to the ocular tissues with irreversible consequences, and so we need to optimize visual outcomes. We know that corticosteroids, whether local or systemic, are the mainstay of therapy for uveitis, but they're relatively short acting, and you do have small flares of uveitis which typically occur between these corticosteroid treatment phases. So the objective of treatment of uveitis, for that matter recurrent uveitis, is to have a sustained control of inflammation, especially non-infectious uveitis, and if it is infectious uveitis, we have to take care of the bug. So the choice of therapy when it comes to non-infectious uveitis, where the posterior segment is by and large involved, or when you have a chronic uveitis or you have uveitis with autoimmune disease, you need to treat them with systemic corticosteroids, with or without immunosuppressive drugs. And patients who have solely anterior uveitis, they usually respond very well to topical treatment, and systemic drugs are usually not necessary. So let's see the first condition and the commonest that we face is acute anterior uveitis. And we see that you must be wondering why we always order the HLA-B27 in our clinic, because they're frequently associated with HLA-B27 haplotype and spondyloarthropathies. And this type of uveitis has a tendency to recur in a variable period of time. You may have multiple episodes in a year, you may have 3 or 6 or any number of episodes. So the sulfasalazine drug, which is known to prevent recurrences and also reduce the severity of uveitis attack in these patients. Now this has been recommended as the first line therapy in acute anterior uveitis patients who have recurrent uveitis, that means who have more than 2 episodes per year. And the relation between this drug and anterior uveitis is that these patients have bowel inflammation, and what this bowel inflammation does is it increases the gut permeability, which increases absorption of the exogenous antigens into the general circulation, which initiate anterior uveitis. So this drug, which is the principal treatment drug for IBD, reverses the bowel permeability, hence decreases the attacks of anterior uveitis, and it has a good therapeutic index, minimal side effects, a very safe drug, and those who do not tolerate this drug are put on methotrexate. So the dose that is given by our rheumatologists in these patients is they start with 500 mg BD for 1 week, then they go on to TID for a week, and then 1 gram BD, and they prefer to put these patients on lifelong therapy. This is just to prevent the attacks. So when you treat recurrence, the idea is to prevent recurrence, and you have to have a prophylactic attitude towards these patients. The next common uveitis, which is very frequently recurrent, in fact always recurrent, is GIA associated uveitis. And first thing that we know is that as soon as the diagnosis of GIA is confirmed or suspected in any child, we must start screening of those children for uveitis. And once we detect uveitis, we follow a step ladder approach. The first management is, of course, we give steroids, topical and oral, along with one immunosuppression suppressive agent, which is usually methotrexate. If these children are not controlled on one drug, we go on to 2 drugs, and then we go on to the biologics. So I give you an example of a case which we started managing way back from 2009 onwards. This was a young girl who was was diagnosed with GIA, chronic uveitis. She was put on methotrexate and she did very well. She remained in remission for almost 7 years. And then she comes back with cellular reaction in the right eye. And then she was added on to mycophenolate, which was the second drug. 4 months she did fine, and then she threw up a recurrence on this drug. And then because the other issues were there, she used to come from Bihar, compliance was an issue. So this patient was put on anti-TNF agents, which I said as the biologics. So she was put on this and she's been doing fine on this drug for 3 years. Coming to the viral interior uveitis, again where we see a lot of recurrent pattern of uveitis. When you have HSV interior uveitis, of course I'm not going to go into the details of the conventional management because that's a separate topic altogether. But just to make a passing reference, when we give oral acyclovir 400 milligrams 5 times a day for 4 weeks, that is for a month, or you can give oral valacyclovir along with the topical inflammatory therapy and cycloplegic therapy. But in those patients who have severe uveitis or recurrent uveitis, they need a maintenance dose, which is usually recommended as oral acyclovir 400 milligrams BD, which can go on for maybe 3 to 12 months. There's no consensus, but this is what the practitioners have gone over. Or oral valacyclovir 500 milligram BD. Of course, these drugs are renal toxic, so you need to monitor the RFTs. Coming to the vis-a-vis interior uveitis, we start with oral acyclovir 800 milligrams 5 times a day for about a month, or oral valacyclovir 1 gram TID for a month, along with the topicals. And then when the patient is a known case of a recurrent uveitis and chronic indolent course of uveitis, you need to put them on maintenance dose of oral acyclovir 400 milligrams BD or oral valacyclovir 500 milligrams OD for 3 to 12 months. Depending upon the number of times, depending upon the severity of uveitis. CMV interior uveitis responds very well to the topical therapy of ganciclovir ophthalmic gel, which is 5 times a day for induction, followed by maintenance dose, which may vary from 1 to 4 times a day. Oral ganciclovir is also another option, 900 milligrams BD for 3 weeks, followed by a maintenance dose of 450 milligrams BD for 4 weeks. Acute retinal necrosis. Now, one good thing about viral posterior uveitis as compared to anterior uveitis is it does not show a very recurrent pattern, and generally they respond very well to the antiviral therapy, and we do not have these patients coming back with the recurrence. Of course, they do turn up with the sequelae, but that's a different thing altogether. So, acute retinal necrosis, we note there is an induction therapy, and the maintenance therapy is again given to prevent any relapse. So, acyclovir, when we give as the IV, 10 to 15 milligrams per kg in 3 divided doses for 2 weeks, followed by 800 milligrams oral 5 times a day. So let's come to the second line, where that means the patients who are non-responders or who have not responded well to the conventional acyclovir therapy. So they may be added with ganciclovir intravitreal injections. Again, in the induction phase, you can repeat twice a week, and then followed by weekly doses depending on seeing the clinical response of uveitis. Tubercular uveitis, sir has covered very well. I will not go into the details, but just to mention that why do we give anti-TB therapy to these patients? Because initially they do respond to corticosteroids. So the idea is to eliminate the bug and to prevent recurrences. And this has been shown by a large number of studies, especially the COTS group, that ATT reduces recurrences, and even with our own experience almost more than a decade back. So the conventional treatment is the first line 4-drug therapy, where we give 4 drugs for 2 months, followed by 2 drugs for 7 months, along with pyridoxine supplementation and monitoring our LFTs. Now the problem is, when these patients come back with a recurrence, you need to see why they are recurring rather than jumping on to another course of ATT and just high dose steroids. You need to check compliance, because ATT needs a lot of compliance. It's a toxic regime, long duration, so you need to check compliance, number one. You need to rule out a non-tubercle etiology, because sometimes we may be erring on the side of giving ATT where it is not required. And then if you make sure that yes, this was a tubercular uveitis which has come with recurrence, we give immunosuppressive therapy. So an example of a male who presented with decreased vision for 4 months was treated elsewhere as TB. Simply for the reason, if you look at his investigations, he had undergone a number of investigations, and the ones highlighted in red were the ones which were paid attention by the treating ophthalmologist. And just because his Montux was very high and he had some lymph nodes on the CT chest, He was given a course of anti-TB therapy along with steroids, not very high dose. So we identified when we dilated him, we found that it was actually a sunset low fundus and nothing else going on. We did the OCTs and found there was resolving subretinal fluid, partly because of the steroids that he was exposed to, thickened choroid. So this was nothing but a case of VKH, where erroneously it was treated as TB uveitis, and probably the patient would have gone on and on with ATT or second line drugs. So it's important to identify whether it's a non-tubercle etiology. So we hide the steroids, put the patient on immunosuppression, and then you can see the choroidal thickness is decreasing, subretinal fluid is going both in the right and the left eye. So every case of latent TB with uveitis does not need ATT, please keep in mind. Coming to the paradoxical worsening, because when we talk of recurrence, this is again a major issue. So many times we think that the patient has thrown recurrence when the patient is already on ATT. It's not so, it's just the paradoxical response. And this can be taken care of by intensifying your steroids or even adding in Ozurdex like we did in one of these patients, and they do well with intravitreal dexamethasone implant. Ocular toxoplasmosis is again another challenge where you see these patients coming back with recurrence again and again. So recently we have had this current practice in the management of ocular toxoplasmosis by the study group, which involved a number of countries and all the practicing ophthalmologists who see patients of toxoplasmosis. So the first line therapy of toxoplasmosis is of course a systemic antimicrobial drug, which is usually the preferred combination is trimethoprim with sulfamethoxazole, which is available as Cetran, along with intravitreal clindamycin, which is now preferred over the oral clindamycin, with or without dexamethasone. And this treatment is given for 6 to 8 weeks or till the lesion is clinically inactive. So this was just a patient, you can see there is a lesion in the periphery. We treated with the conventional therapy. This was way back in 2012. 2 years, you can see there is a scar, the patient was doing fine. And 6 years later, this patient comes back with a recurrence. So adjacent to the previous scar. So what do? We treated the patient with the same treatment because we don't have really any guidelines how you treat the second episode or the third episode. So what we did was we gave the intravitreal along with the systemic therapy, and this is how the patient responded at 5 weeks. But it's not so. You may keep on having these challenges, and 7 years later the patient again comes back with the recurrence of interior uveitis this time. So as per this study group members, they prescribe trimethoprim sulfamethoxazole as a prophylaxis against recurrent ocular toxoplasmosis, and the duration has been seen variable. Many of them it's taken as minimum of 6 months, but you can go up to 24 months. Behçet's uveitis is again a recurrent chronic disease. So the most commonly used conventional treatments are antimetabolites, T-cell inhibitors, alkylating agents. So what we use in our practice is a combination of azathioprine and cyclosporin A along with corticosteroids. The reason is that this combination is more effective, has been proven in randomized and controlled trials and also in clinical studies. But in recently 2018, the EULAR, that is the European League Against Rheumatism, has updated its recommendations for patients of Behçet's disease with first-time uveitis with the same therapy that I mentioned, and those with a history of recurrent uveitis or non-responders where the anti-TNF agents like the adalimumab or infliximab has been added as a first-line therapy. So VKH disease, I mentioned high-dose steroids along with immunosuppression therapy. The older school of thought was you give immunosuppression therapy when you start tapering the steroids, but it's not so now, because nowadays it is preferred that the immunosuppression therapy should be started along with the high-dose corticosteroid therapy, simply for the reason that when you catch the patient in the acute stage, the underlying immune process which is going on is in a very immature stage. So if you arrest that phenomenon by immunosuppressive agents, it acts lifelong, and that really prevents recurrences in these patients. So the key points are the chronic or recurrent uveitis needs a long-acting treatment rather than giving multiple repeated short-acting treatments in the form of high-dose steroids. But of course, for these patients who have a lot of challenges, you need to have a multidisciplinary and an individualized treatment for each patient. Thank you very much.